Welcome to this Step 2 clinical knowledge review on postpartum care test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for postpartum care topics, including normal postpartum changes, postpartum hemorrhage, postpartum depression, and breastfeeding counseling. We will teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the obstetrics and gynecology sections of first aid and your question bank before or alongside this video. Here is what we will cover today. First, we will learn to recognize high-yield question stems for postpartum care on board exams. Second, we will apply test-taking strategies specifically for postpartum hemorrhage, postpartum depression, and breastfeeding counseling questions. Third, we will master the next best step question format for managing common postpartum complications. Before we start, I want to remind you to review the obstetrics and gynecology chapters in first aid and your question bank for the foundational content. This video focuses on how to apply that knowledge strategically on exam day. Our first strategy is learning to tell normal from abnormal in the postpartum period. The boards love to give you a postpartum patient and test whether you can identify what is expected versus what needs intervention. On the normal side, remember that Lochia changes color over time, going from red, called rubra, to pinkish serosa, to white alba. The fundus drops about 1 centimeter per day. After pains are expected, especially with breastfeeding, and a low-grade temperature in the first 24 hours can be completely normal. On the abnormal side, watch for foul-smelling Lochia, which suggests endometritis. A boggy or non-descending fundus suggests hemorrhage. Any fever beyond the first 24 hours needs further workup. And persistent bright red bleeding after day 4 is a red flag. The exam loves to present a normal finding as if it is concerning, so do not be tricked into ordering unnecessary workups. Strategy 2 focuses on postpartum hemorrhage, which is one of the most tested topics in obstetrics. The key framework to remember is the 4 T's: tone, trauma, tissue, and thrombin. Uterine atony, which falls under tone, is by far the most common cause. When you see a question describing a boggy, soft uterus with heavy bleeding after delivery, your first answer should be bimanual uterine massage and uterotonic medications. Risk factors the boards love to include are over-distended uterus from things like twins, too much amniotic fluid, or a large baby. Prolonged labor and infection of the membranes are also risk factors. For the other causes, retained placenta will show an incomplete placenta on inspection. Lacerations will show continued bleeding despite a firm, contracted uterus, and coagulopathy will show oozing from multiple sites without good clot formation. The boards want you to systematically work through these causes based on the clinical clues. Now let us look at how these topics appear as question stems. For postpartum hemorrhage, expect a patient who just delivered after a prolonged labor with heavy vaginal bleeding and a boggy, soft uterus. The question will often include risk factors like an over-distended uterus or prolonged use of oxytocin. The first step is always fundal massage and uterotonic medications. For postpartum depression, the classic stem is a patient 2 to 6 weeks after delivery with persistent sadness, loss of interest in the baby, difficulty bonding, and feelings of guilt. The key differentiator from baby blues is timing. Baby blues resolves within 2 weeks. If symptoms persist beyond 2 weeks, it is postpartum depression and requires treatment. For breastfeeding complications, look for a lactating patient with unilateral breast pain, redness, fever, and flu-like symptoms. This is mastitis. The important thing to remember is that breastfeeding should continue with mastitis. If there is a fluctuant mass, that suggests an abscess, which needs imaging and drainage. Let us work through our first practice question together. Read the stem carefully. We have a 30-year-old woman who just delivered after a prolonged 18-hour labor with oxytocin augmentation. Within 30 minutes, she has heavy vaginal bleeding with clots. Her uterus is above the umbilicus and feels soft and boggy. She is also showing signs of hemodynamic instability with low blood pressure and a fast heart rate. Take a moment and think about what the most likely cause is and what your first step should be. The answer choices are A, bimanual uterine massage, B, surgical exploration, C, transfusion of packed red blood cells, D, hysterectomy. Think about which one you would pick before we go to the next slide. Let us walk through this answer. Step 1. Spot the pattern. We have a prolonged labor with oxytocin use, a boggy uterus sitting above the umbilicus, and heavy bleeding. This is textbook uterine atony, which is the most common cause of postpartum hemorrhage. Step 2. Apply the rule. The board rule is that bimanual uterine massage and uterotonic medications are always the first step for uterine atony. You must try conservative measures before going to surgical options. This sequence is critical on the exam. Step 3. Eliminate wrong answers. Choice B, surgical exploration, is premature because you have not tried conservative management first. Choice C, transfusion, is supportive care that does not address the underlying cause of the bleeding. Choice D, hysterectomy, is a last resort that you only consider after all other measures have failed. The correct answer is A, bimanual uterine massage. Remember, the boards love testing whether you know to start with the least invasive intervention first. Here is our second practice question. We have a 26-year-old first-time mother presenting 6 weeks after delivery with persistent sadness, loss of interest in activities, difficulty sleeping even when the baby sleeps, poor appetite, feelings of worthlessness and passive suicidal ideation, saying her family would be better off without her. She denies hallucinations or thoughts of harming her baby. Take a moment and think about what the diagnosis is and what the best next step would be. The choices are A. Reassurance that this is normal baby blues. B. Starting a selective serotonin reuptake inhibitor. C. Immediate inpatient psychiatric admission. D. Referral for cognitive behavioral therapy alone. Think about your answer before we move on. Let us break down this answer. First, read the question carefully. This patient is 6 weeks postpartum, which is well beyond the 2-week window where baby blues would resolve on its own. She has classic features of major depression, including loss of interest in activities, sleep disturbance that goes beyond normal newborn care, appetite changes, feelings of worthlessness, and passive suicidal ideation. This is postpartum depression, not baby blues. There are no psychotic features like hallucinations or delusions, and she is not having thoughts of harming her infant, so inpatient admission is not indicated at this point. Why is medication the right answer here? First-line treatment for postpartum depression is a selective serotonin reuptake inhibitor. Sertraline is the most commonly tested choice because it is considered safe during breastfeeding. Choice A, reassurance, would be dangerous because her symptoms have persisted beyond 2 weeks and she has suicidal ideation. Choice C, inpatient admission, is for postpartum psychosis or imminent danger, neither of which is described here. Choice D, therapy alone, is insufficient for moderate to severe symptoms with suicidal ideation. The correct answer is B. Breastfeeding counseling is a high-yield board topic because the exam loves to test when to continue and when to stop breastfeeding. On the continue side, mastitis actually requires continued breastfeeding or pumping to prevent abscess formation. This is counterintuitive and heavily tested. Most maternal medications are compatible with breastfeeding, so do not pick an answer that says to stop breastfeeding just because a mother is on medication unless it is specifically contraindicated. Hepatitis B. Positive mothers can breastfeed as long as the infant receives immunoglobulin and the vaccine at birth. On the stop side, active untreated tuberculosis with pulmonary involvement is a contraindication. Certain chemotherapy agents are contraindicated. Active herpes simplex lesions on the breast are a contraindication, but only on the breast, not elsewhere. And human immunodeficiency virus is a contraindication in resource-rich settings like the United States, but not in resource-limited settings. The boards test these distinctions frequently. Here is our third practice question. A 32-year-old breastfeeding mother comes in 10 days after delivery with 2 days of right breast pain, redness, and swelling. She has a fever of 38.8 degrees Celsius. On exam, the right breast is red, warm, and tender in the upper outer quadrant. There is no fluctuant mass. The answer choices are A. Stop breastfeeding and apply cold compresses. B. Oral antibiotics and continue breastfeeding. C. Incision and drainage. D. Breast ultrasound before any treatment. Take a moment to think through this question. What are the key findings, and what does the absence of a fluctuant mass tell you? Let us break this one down. Spot the classic pattern. We have a breastfeeding mother with unilateral breast pain, redness, warmth, and fever. There is no fluctuant mass. This is textbook lactational mastitis. The key detail the exam is testing here is the absence of a fluctuant mass, which rules out a breast abscess. Know the key distinction. Choice A says to stop breastfeeding, which is exactly wrong. Stopping breastfeeding actually worsens mastitis and promotes abscess formation. This is a classic trap answer. Choice C, incision and drainage, is the correct management for a confirmed abscess with a fluctuant mass, but that is not what is described here. Choice D, getting an ultrasound first, is unnecessary when the clinical picture is straightforward and there is no palpable mass. The correct answer is B, oral antibiotics and continue breastfeeding. The antibiotic of choice is typically dicloxacillin or cephalexin to cover staphylococcal infection. Remember, continued breastfeeding is therapeutic in mastitis. Here is a critical test-taking pearl about the postpartum timeline. The boards love testing whether you can distinguish conditions based on when they present. Baby blues starts within the first few days and resolves on its own by 2 weeks. If you see a question with mood symptoms that resolve within 2 weeks, the answer is reassurance. Postpartum depression presents within 4 weeks per the diagnostic criteria and can last for months without treatment. This requires pharmacotherapy, usually a selective serotonin reuptake inhibitor. Postpartum psychosis is the most dangerous and presents within the first 2 weeks with hallucinations, delusions, and bizarre behavior. This is a psychiatric emergency requiring hospitalization. Endometritis typically presents within the first 5 days with fever, uterine tenderness, and foul-smelling lochia. Also remember that Rh-negative mothers need anti-D immunoglobulin within 72 hours of delivery. These timing windows are heavily tested, so memorize them. When you see a postpartum question, the first thing you should do is look at how many days or weeks postpartum the patient is, because that alone can narrow your differential significantly. That wraps up our review of postpartum care test-taking strategies for Step 2 clinical knowledge. Let us recap the key takeaways. First, always distinguish normal from abnormal postpartum findings. Do not get tricked into ordering unnecessary workups for normal findings like Lochia changes or afterpains. Second, for postpartum hemorrhage, remember the 4 T's and always start with bimanual uterine massage for Atony. Third, know your postpartum timeline to distinguish baby blues, postpartum depression, and postpartum psychosis based on timing and severity. Fourth, remember that breastfeeding should continue with mastitis and know the specific contraindications to breastfeeding. For more in-depth review, go through the obstetrics and gynecology chapters in First Aid and your question bank. Focus on the management algorithms for postpartum hemorrhage, the diagnostic criteria for postpartum mood disorders, and the contraindications to breastfeeding. Visit roadmap2residency.com for expert tutors and residency advisors who can help guide your board preparation and match strategy. If you found this video helpful, please like and subscribe to our channel for more high-yield board review content. Good luck on your exam, and we will see you in the next video.